I'm Dr. Russell Jennings, pediatric thoracic surgeon in the Esophageal, Airway, and Thoracic Center in Johns Hopkins All Children's Hospital in St. Petersburg, Florida. And I'd like to discuss the Diverticulum of Kommerell. Basically, an artery is usually the same size along its length. In a diverticulum, it gets bigger. Now, why is that important? The Diverticulum of Kommerell was described by German radiologist Dr. Kommerell in 1936 as an aberrant subclavian artery with a dilation at the base of it next to the aorta. Basically, if this is the aorta, and there's an aberrant subclavian artery coming off here, this part was bigger. And that right there is called the Diverticulum of Kommerell. It's merely a large part, but it has several problems in that it's taking up space. It can cause esophageal compression, making it hard to swallow. It can compress the airway or the trachea, making it hard to breathe. It can become aneurysmal, which means it becomes quite big and very thin-walled. It can get blood clots in it, which can then shoot off, called emboli, and those would go down this subclavian artery to the hand or the fingers. It can compress the structures around it, like the vocal cord nerve, called a recurrent laryngeal nerve, and paralyze a vocal cord, or even both. It can also rupture, letting a lot of blood come out very rapidly that could be lethal, and it can cause an aortic dissection, which can also be a lethal event. First, I want to discuss normal anatomy. This is the normal esophagus, just behind the trachea, which has a soft membrane and cartilaginous rings, right here. And in front of that is the aorta. This is the ascending aorta, the transverse aorta, and the descending aorta, which sort of wraps around the left mainstem bronchus right here. Normally, all the blood vessels of the aorta are in front of the trachea. Here's the left subclavian artery, the left common carotid artery. This is the brachiocephalic trunk going into the right common carotid artery, and it goes into the right subclavian artery. Now, what we haven't really described here are the other important structures. The vagus nerve on the left runs down here behind the aorta, comes around here, and then the recurrent laryngeal nerve comes up and runs along the carotid artery to go up to the larynx where it feeds the vocal cord nerve. It runs right around a structure right here we can't see in this picture called the ductal ligament, which is a necessary ductus arteriosus in fetal life, but becomes a scar in the first week or so of life. On the right side, we have a vagus nerve that comes down. But interestingly enough, as the vagus nerve goes down, it branches off the right recurrent laryngeal nerve, which then goes up to feed the right vocal cord. Now you'll notice that the right recurrent laryngeal nerve comes off the subclavian, and the left goes around the aorta, around the ductus arteriosus or the ductal ligament. These are important concepts, which we'll talk about why in just a moment. This is another illustration showing the relationship from the front in normal anatomy. The ascending aorta has been removed. If we look at normal anatomy from the back, we can see right here is the esophagus, which would normally be right against the spine. And we can see that the descending aorta runs basically next to the esophagus, never really impinging upon it. And we can see in front of the esophagus is the trachea right here, so that all those structures are sort of independent and not compressing each other. Now, how about when we have an aberrant subclavian artery? Well, let me tell you what that is. I've already described that a little bit in a previous video on aberrant right subclavian arteries, but basically if we have a normal aorta from the back, the descending aorta is right here, and we would have a ductal ligament about right here, and this is the transverse arch, which is running over the left mainstem bronchus. In the case of an aberrant subclavian artery, this artery, which is the subclavian artery, doesn't come off at this point. Instead, it comes off down here. And this is a drawing of an aberrant subclavian artery right here. And it joins the aorta right here. And it has this diverticulum of Kommerell, which is that dilated segment joining the aorta. It's not the entire artery, but it's a short segment. And you can see that that diverticulum of Kommerell is taking up space, which is compressing the esophagus, illustrated here. You can see how that's compressing the esophagus. This is a drawing from an anatomic specimen, and you can see in this anatomic specimen, or cadaveric, this is the esophagus, and it seems to be sort of deviated a little bit to one side by this structure right here, which is a diverticulum of Kommerell joining a aberrant right subclavian artery, and this here is the aorta. So you can see that motion of the esophagus here is compressing a little bit. This is done in a drawing right here, where you can see the right subclavian artery, which comes off here, and you can see the dilated segment right here, which is the diverticulum of Kommerell, and you can see how the esophagus is pushed forward. It's going around that diverticulum of Kommerell. Well, on this side of the esophagus is the trachea, so it's leaning right against the trachea. So that's part of the problem. There's only so much space in the mediastinum, and when the diverticulum of Kommerell expands, it pushes on the surrounding structures, including the esophagus and the airway. This is an adult with an angiogram who has a left aortic arch, which is normal side, and has an aberrant right subclavian artery. From the front, you can see the ascending aorta and the branches, and what we can see in the back is this dilated segment going up to the aberrant right subclavian artery. We can see this better from the back. Here's the descending aorta right here. And we can see this dilated segment right here is the diverticulum of Kommerell going to the aberrant right subclavian artery. Well, when we see the CT scan, we get a better idea of exactly what's going on. Because here is the left aortic arch, and here is the diverticulum of Kommerell. And what we can see, even more importantly, is that right here is the esophagus, very compressed, making it very hard to swallow. And right here is the trachea, which is somewhat compressed, but in this case, not severely. We can see this on the side. We can see that here's the aberrant right subclavian artery, and here this is the diverticulum of Kommerell, which is quite dilated, and this is the descending aorta. So you get an idea of the consequences of a diverticulum of Kommerell on the esophagus, in this case, when it's compressing the esophagus quite severely, making it hard to swallow. So this is a series of pictures which demonstrate the consequences of a diverticulum of Kommerell on the esophagus. So this is an esophagram. We put contrast in the esophagus to see how it fills, and normally it would look like this. But in this case, we have this defect, which is caused by the diverticulum of Kommerell compressing the esophagus, and here it's pushing on the side of the trachea from that diverticulum of Kommerell, pushing everything forward. We can see on the right side pictures more of these. We can see here diverticulum of Kommerell, diverticulum of Kommerell, diverticulum of Kommerell, compressing the esophagus, making it difficult to swallow. So here we see the inside of the esophagus using an endoscope in a person who has a left-sided aortic arch with a aberrant right subclavian artery. Now what we can see here is the compression of the esophagus from here to here by the aorta, making it much smaller. And here we can see compression of the esophagus by the diverticulum of Kommerell and the aberrant right subclavian artery. This esophagus is pretty compressed and making it hard to swallow. Normally on endoscopy, we would see this as something about this big. So you can see it's really compressed. So here's another picture of a child with a left aortic arch, aberrant right subclavian artery, and a diverticulum of Kommerell. You can see the trachea here is pretty compressed by the esophagus, which is compressed by the diverticulum of Kommerell and the aberrant right subclavian artery. When you look inside the trachea, and this is the trachea on the right side of the picture, this is the esophagus pushing forward on the trachea, compressing it. Normally this trachea would look something about like this. So it's a significant compression. And on the front is the pulmonary artery pushing on the trachea because the trachea is pushed forward. Cut of the CT scan from the side, you can see the ascending aorta starting the transverse arch coming here, and you can see the trachea is moved forward and compressed against the pulmonary artery, which is right here, and against the aorta. We can also see these airgrams are the esophagus right here, and it goes up and around this diverticulum, which is right here. And by going around it, it's compressed, so it's almost completely closed right here. And that's making it hard to swallow. This part compressed right here is that part right there, which you can barely see. Well, diverticulum of Kommerell can also occur if you have a right-sided aortic arch. Now, right aortic arch is not normal. And it can be completely asymptomatic, but if you have a right-sided aortic arch associated with a left subclavian artery, and this would be an aberrant left subclavian artery right here, because it's coming off of the back of the arch instead of coming off up here where it belongs. And this is the diverticulum of Kommerell coming off of the aorta. Right here is the descending aorta and the arch right here. Here you can see a right aortic arch with an aberrant left subclavian artery with the diverticulum of Kommerell, and we can see the effects of that diverticulum. In this case, the esophagus, which is right here, is considerably compressed by this diverticulum right here, and it's compressing that esophagus forward to impede or impress the trachea and compress the trachea from the back. This is a beautiful drawing of a right aortic arch with an aberrant left subclavian artery and a diverticulum of Kommerell. From the front, we can see the ascending aorta going around the right side of the trachea, which is right here, and you can see the esophagus behind it. When we look from the side, you can see the aorta is wrapping around the left mainstem bronchus. And we look at from the back, we can see the right aortic arch, which is coming around here, and the descending aorta right here, impressing the back of the esophagus. But more importantly, we see this structure right here, which is the diverticulum of Kommerell, from which comes off the aberrant left subclavian artery. And we can see on the side view, this diverticulum of Kommerell is pushing on the esophagus, which is pushing into the trachea, causing compression of both the esophagus and the trachea. So we can see that the diverticulum of Kommerell is very important. This is a picture of a right aortic arch with the left aberrant left subclavian artery. And you can see that in this picture, the esophagus is really compressed. This is the esophagus, and it should be as big as the trachea, but it's really compressed. What's it compressed by? Well, this is really important. This is the aberrant right, this is the right aortic arch. This is the diverticulum of Kommerell, and this is the left subclavian artery. This is the left subclavian artery. It's the diverticulum of Kommerell that's causing the esophageal and tracheal compression. It's not the aberrant left subclavian artery. You can see that here's the aberrant subclavian artery coming off, and here's the diverticulum of Kommerell coming off of the aorta right here. This yellow structure is the trachea, and you can see how the trachea is right in front of that diverticulum, and in this particular picture they took out the esophagus so it didn't make it hard. But you can see how that diverticulum is pushing right onto the back wall of the esophagus and right onto the trachea. And this is another picture, reconstruction of a CT scan. You can see this is a right aortic arch with an aberrant left subclavian artery. So here's the aberrant left subclavian artery, which is normal size. This is a little bit bigger. This is the diverticulum of Kommerell coming off of the aorta right here. So this child has an esophagus which is in green, and you can see how it looks compressed right here, right by the diverticulum of Kommerell, and that esophagus is being pushed forward right into the back wall of the trachea, which is in red. What this shows is the consequences of the diverticulum. This is the diverticulum right here, and that's the aberrant left subclavian artery right there. You can see the diverticulum is bigger. You can also see that the esophagus, which is right here and right here, is very much compressed in this tiny, tiny space right here. And that's where you get the esophageal compression directly by the diverticulum of Kommerell. You can also see pretty easily that the trachea is compressed in the same space. It's so that in this particular child, there's trouble with swallowing and breathing. When we look on the coronal image, like we're looking at the front and we're close to the spine here, we can see that here's the subclavian artery, here's the diverticulum of Kommerell, and here's the aorta and the right arch. Just giving you an illustration of how much bigger than the subclavian artery the diverticulum of Kommerell is, and why it's right behind the esophagus and the trachea. So this is a very illustrative series of pictures. So let me go through this very carefully because this is important. This is a CT scan, a coronal, or I'm sorry, an axial view. This is the ascending aorta. This is the descending aorta. And this is the diverticulum of Kommerell going up to the subclavian artery right here. What we can also see very plainly is the trachea, which should normally be about like this, is significantly compressed and distorted. And the esophagus right here is all smushed flat against the trachea. It should have lots of space to expand. So the diverticulum of Kommerell in this case is pushing up on the esophagus. The esophagus is then pushing up on the trachea and distorting and compressing it. We can see the diverticulum of Kommerell on this reconstruction angiogram from the back. Here's the descending aorta. Here's the arch, which is on the right side. And you can see the diverticulum of Kommerell is right here, and the aberrant subclavian artery is right there. So you can see how it's much bigger than the subclavian artery. Well, what happens after the surgery to correct this problem? Well, here's an axial CT scan. Again, this is the ascending aorta right here. This is the descending aorta. And in typical fashion, in my personal opinion, not the best way to fix this, the diverticulum of Kommerell remains. It's right here. Here's the diverticulum of Kommerell with a little tie on it. And the trachea, because the diverticulum of Kommerell is still there, is still distorted. It looks almost exactly the same here as it does here. Really no effect because the diverticulum of Kommerell is the problem. We'll look at the CAT scan angiogram reconstructions and we can see what they did. Here's the descending aorta from the back, and here's the arch. This is the diverticulum of Kommerell right here, which looks not that different than this diverticulum of Kommerell right there. They did take this vessel off right here, and they moved it up to the carotid artery right here. So they did the correct reconstruction, but they left behind the diverticulum of Kommerell, continued airway compression, and continued impression of the esophagus. Why didn't the esophagus expand even though it slipped to the side? Because in vascular rings, the esophagus and trachea, when compressed, get tightly locked into scar tissue. And even though they take off the aberrant subclavian artery, if they don't release all that scar tissue and move the esophagus off to the side, you haven't really accomplished much. And if you leave the diverticulum of Kommerell in place, you haven't stopped the ongoing pressure. You still have all the risks of a diverticulum of Kommerell, which we described at the very beginning, and you haven't really relieved any of the obstruction. So it's very common to have vascular ring surgery and still have symptoms afterwards because they didn't take down the scar tissue and they didn't take off the diverticulum of Kommerell and they didn't move the esophagus out of the scar tissue. Here's a beautiful MRI, which is different than a CAT scan, so colors are different, but here's a beautiful MRI demonstrating a right aortic arch right here. Here's the diverticulum of Kommerell right here. Here's the aberrant subclavian artery, and you can see in this picture the trachea is very flat. It should be wide open. And the esophagus is very flat. Remember, it needs space to expand. So in this case, the diverticulum of Kommerell, which is probably right here, is compressing the esophagus, and the esophagus is compressing the trachea. When we look inside the airway with the telescope, this is the picture of the airway from the telescope, we can see there's a right aortic arch right here, and we can see there's a big impression right here of the trachea. Remember, the trachea should look basically like that. So there's really a lot of compression on this trachea from the diverticulum of Kommerell pushing the esophagus into the back of the trachea, and the right aortic arch is trapping it and keeping this side from expanding. The diverticulum of Kommerell has now come to mean not just an aberrant subclavian artery with a dilated base, but has also come to be used for any artery which has a dilation at its insertion into a bigger blood vessel. And in this case, this is the ductal ligament, which is a ductus arteriosus, which we're all born with and closes up, but sometimes it'll get a dilation at its base, and they call that a diverticulum of Kommerell as well, although it's not totally pure because Dr. Kommerell did not describe that. So how to repair a vascular ring with compression of the trachea and the esophagus? Well, in my opinion, you have to address the primary problem, which is the diverticulum of Kommerell. The secondary problem is the aberrant subclavian artery. So if this is the left subclavian artery, so this is the left subclavian artery. In this case, it's a right arch with an aberrant left subclavian artery. The left subclavian artery comes down here. This is the diverticulum of Kommerell inserting into the aorta right here. And this is the problem, which is compressing the esophagus and the trachea. Now, it's not such an easy problem because we talked earlier that about right here, somewhere in here is going to be a ductus. And where there's a ductus, there's going to be a vagus nerve coming down. And right here is where the recurrent laryngeal nerve is going to wrap around. And on the right arch, the recurrent laryngeal nerve always goes around the right arch. So in this case, we're going to have the vagus nerve coming down, and I can't really show it on this picture, but we're going to have the recurrent laryngeal nerve is going to be wrapping around the arch right in that area. So in this area also is the esophagus. Remember, there's the esophagus, which is running right here. Between those vagus nerves and the recurrent laryngeal nerves, and the trachea is right in here as well, right on top of the esophagus. So in that space where the diverticulum of Kommerell is compressing the esophagus, there's a lot of scar tissue around the esophagus because of the compression. There's also both recurrent laryngeal nerves going to the vocal cords and both vagus nerves. So this surgery to resect the diverticulum of Kommerell is not easy because it requires recurrent laryngeal nerve monitoring. Nerves must be monitored continuously so we know where they are so they can stay out of harm's way. And that takes a different type of anesthesia. Nevertheless, in the appropriate hands where we can have recurrent laryngeal nerve monitoring, we are confident that we can move the esophagus out of the way and cut all the scar tissue without causing harm. We then will remove that diverticulum of Kommerell completely and fix the aorta. We then need to get blood flow back into the arm from this left subclavian artery. And we do that by reimplanting this subclavian artery into the carotid artery up there. And when we're all done, the aorta looks normal here. There's no diverticulum of Kommerell. And the aberrant left subclavian artery is now in a more normal position attached to the left carotid artery. So now I have normal blood flow. We don't have a diverticulum of Kommerell. We've monitored the nerves very carefully so that we don't have any nerve damage, particularly to the vocal cord nerves. And we've moved the esophagus out of all that scar tissue, so it's not going to be continually compressed by that scar tissue after surgery.